Good morning, everyone. I would like to thank Suma ma'am for this opportunity to be part of such an interesting and challenging topic at a CVI. So, why is it important, like you just asked, why is it important to differentiate CVI from other causes of visual impairment? This is because CVI children, they exhibit such distinct visual behavior that at times it is very challenging to differentiate. So when we talk about low vision or the visual impairment, it is defined as a visual acuity of less than 6/18 to light perception, or a visual field of less than 10 degrees from the point of fixation after treatment or the standard refractive correction has been given, and one can use or is potentially able to use the vision for planning and execution of a task. So like when we see visual impairment in children, there are different causes. You have CVI as one of the most common cause of visual impairment in children, as the incidence is increasing because of the better survival rate of these preterm children or children with severe neurological damage. Since their survival rate is increasing, so the visual impairment is also increasing in these children. Then we have the OVI children who have ocular disorders, and that is leading to the visual impairment. So, Suma ma'am has already covered all the visual assessment tests, so I will just talking about clinical differences between these two conditions. So, if we talk about CVI children, CVI should be suspected as a diagnosis whenever you see unexplained bilateral decreased vision in children. That means the pupillary reaction may not be completely normal in these children, and you might also see some intermittent, unsustained bursts of nystagmus. Then there are defective smooth pursuit movements, inability to perform the visually guided saccadic movements which are seen in these children. There may be coexisting optic atrophy or other ocular manifestations also in CVI children, because in 40% of the cases it has been seen that CVI and the ocular disorders might coexist. But these children definitely have neurological deficits, like you may come across children with cerebral palsy, seizures, microcephaly, some progressive CNS degeneration or hydrocephalus. So all these conditions might be there. Whereas if you talk about the OVI, these children, they usually have a unilateral or a bilateral diminution of vision, which is very much explained. The pupillary reaction may be abnormal if it is involving the anterior visual pathways. Nystagmus is typical nystagmus which we see because of the sensory causes, which you can differentiate from the children with CVI, which doesn't follow a typical rhythm of nystagmus. It's just the unsustained beats which we see there. Then, of course, in these children, you will come across ocular disorders, optic atrophy may coexist, or other. After comprehensive eye examination has done, there are a lot of ocular causes which are contributing to the vision loss. So you have got answer to your question. What is the cause of vision loss in these children? And the neurological deficits, they're usually not present in these children. So if we talk about OVI children, the defect lies in the anterior visual pathway, whereas in CVI children, the defect lies in the retrochiasmal pathway. Since the pathways have been discussed, I'll just touch the clinical aspect. So we know that in the occipital lobe, we have all the information stored for the visual acuity, the visual fields, the color vision, as well as the contrast sensitivity. So whereas the pathways which lead from the occipital to the posterior parietal lobe, that is called the dorsal stream, and the pathways where the information is transmitted to the inferior temporal lobe is the ventral stream. So what happens in CVI? If the ventral stream is affected, you have different disorders, and if the dorsal stream is affected, we have different manifestations. So if we talk about the visual acuity, like ma'am has already explained, now when I see a CVI child, there will be a range of impairment of the vision. Like it can be just a perception of light with a child is presenting, or it can be near normal visual acuity. To add on, there is a fluctuation in the visual response which is very categorical. So these children, they might fluctuate in their visual behavior from day to day or from hourly basis also. Now it depends upon a lot of factors. One, where are you examining these children? If you're examining them in a familiar environment, their response will be different. Whereas they are quite anxious when we take them to a novel environment, a new environment. Second, are they under influence of some drugs when you're examining them? Are they fatigued? Are they fresh when they have been brought for examination? Also, are they suffering from any coexisting neurological disorders? So all these are going to have effect on the visual response. And other important aspect is also see for any coexisting ocular disorder. Then, as it has already been told, that they always have a increased visual latency, and they have unstable fixation, or they have a very limited attention span. Sometimes they are misinterpreted also as incapable or poorly motivated kids, while this is not the cause. And they also prefer to see the objects at a very close range, and like we were discussing, a very typical feature in these children is that they turn their head away from the object of reach. This they do to decrease the number of objects in their viewing, so that they can reduce the visual crowding. That improves their performance. In these children, the color vision is spared, but sometimes they have a preference for bright colors like yellow or red colors. And contrast sensitivity might be impaired in these children. And another feature which has been seen is that they have a light preference for light. Or sometimes they might come with mild photophobia if they have the lesions in the thalamus or in the cortex. So if we talk about the dorsal stream, I would just tell the clinical aspect. There is a topographic agnosia, which is these children, they're not able to identify the environmental landmarks. They're not able to identify the orientation. And then there is sometimes inability to identify the objects with the sensation of touch when they're closing their eyes. There may be dyskinetopsia, which means that they're not able to perceive the objects when they are in motion. Or sometimes they might feel that the objects are in a collision course, but actually they aren't. Another typical and very important feature is a simultagnosia, which is that they have a defect in the simultaneous perception. So if they are in a crowded environment, they are not able to identify all the details of the environment. They will be able to specify or fixate on one particular face. So that is why they are very frightened or scary when you take it to crowded environments or in a cluttered environment. So they will be able to fixate on one object of interest. Then ma'am has already told about optic ataxia, which means there's an inability of the visual guidance of movements when they do the visual course. A very typical balance syndrome has been seen in children who have occipital as well as the parietal lesions. This is a triad actually. They have optic ataxia, that means they have inability to for the visual guided movements. Then simultagnosia is there, and also there is a ocular apraxia. Ocular apraxia means that these children, they are not able to maintain the gaze towards the object of interest. When we talk about the ventral stream, then there is a prosopagnosia, that means they have a defect in the recognition of the faces. Achromatopsia is there, and inability to find the directions. They are not able to find their routes, even their way back home. If we talk about the visual field defects, of course they have restriction of the visual fields. They may be homonymous hemianopias, or very typical are the lower visual field defects, because these have inferior quadrantopias. So they also have some adaptations to this. So what they do is that if they have to see something in the lower visual field, they use their upper field to compensate for this defect, or they can even try using their touch sensations to find their way in the lower fields. So if we differentiate the CVI from the OVI, in CVI patients you have an unexplained decreased vision, whereas in OVI you have an ocular cause or ocular disorder which explains the abnormal visual behavior. In CVI, the response to correction of the treatable ocular anomalies is suboptimal, whereas in OVI that correlates with the clinical expectations. The visual behavior is very distinct in CVI, and also the history of neurological disorders present in patients with CVI, which might not be there in OVI cases. The visual latency and the poor attention span, all these are features of CVI children. And of course they have a light gazing behavior, and the colors vision is preserved in children with CVI, which might be defective in OVI. Associated motor cognitive difficulties are seen in children with CVI. Now what is latest being done? Now today everything, virtual reality has really helped us to identify a lot of disorders and also to diagnose these conditions. So there has been a very interesting study in which they have taken the help of virtual reality along with the eye tracking system to assess and also to differentiate the children with CVI from OVI. So basically they had taken 3 groups, and one group was taken as a control, second was a CVI group, and other was a OVI group. In both CVI and OVI group, the visual acuity was quite comparable. So in this, the participant, he was shown a school hallway scene, And then they had different parameters. The main factor was the crowd density. So they kept 3 modules. In the first module, it was a low crowd density of people less than 5, and second was a medium crowd density of up to 10, and higher was more than 15. And they recorded their eye movements through eye tracking system in response to these conditions. Another condition was the cluttering environment, in which the toys were placed in a box and the difficulty levels were raised as the number of toys were increased. So what was seen that the visual responses in children with CVI were much more sensitive. So whenever the difficulty level increased, like it was a moderate or a high crowd density, these children, the visual response decreased as comparable to children with OVI. And similar response was seen in a cluttered environment as well. Their reaction time was much more as the levels of complexity increased. So these children were not able to score well in higher levels of complexity as compared to the OVI children. Also, a sustained gaze error was seen much more in children with CVI. That means they're not able to sustain their gaze for longer periods of time in contrast to children with OVI. Then this data which was obtained was analyzed, and it was presented as a heat map, where the yellow color indicated patient looked at that spot for more time, whereas a blue color indicated patient looked at that spot for less time. So these were the color maps in which you can see the first was a control group, and in the control group it was same whether the complexity was low or higher, whereas in the OVI group, so in the OVI group, if you see, as the level of complexity increased, of course the latency also increased. The blue color, which means that they were looking at that spot for increased time, was much more. But if we compare with the CVI kids, so when the level of complexity increased more further, this span increased even more. So this was an objective way of assessing and differentiating these two disorders. So coming to take-home message, CVI is diagnosed as one of the most common cause of unexplained visual impairment in children, which can be differentiated from visual impairment in with ocular disorders if we study the visual behavior of these children. And children with CVI, they present as a distinct subgroup of visual deficits and might be having coexisting ocular disorders as well. Thank you so much.
Thank you, Reena, for an excellent presentation. We will take the questions after Dr. Sovita's presentation. It is on imaging techniques. I think it's important now also to differentiate CVI from DVM or OVI. We may need to do an MRI, because so in which conditions, because imaging helps us, to differentiate, to find out. Sometimes you are not sure. So which conditions and what MRIs to order, I think Sovita will help us.